So thank you for joining us today. My name is Maggie Cameron. I'm the Director of Development and Communications for the EHE Foundation. Before we get started, as usual, I need to share a few housekeeping items. First, this session is being recorded, so if you find you need to leave before it's over, no problem. We will post the recording to our website and YouTube channels soon. I want to call your attention to the Zoom toolbar at the bottom of your screen. You want to pay attention to the Q&A function. That's where you can submit any questions during the presentation. We will leave time at the end, so just as you think of questions, please feel free to post them there and we will answer them at the end or do our best. We want to remind all participants that the EHE Foundation does not provide medical advice. So the information provided here is for your information only. We encourage you to contact your own healthcare provider for any specific questions about your health. Okay, so to introduce our presenter is the EHE Foundation's Executive Director and Director of Research, Denise Robinson. Welcome. Hi, Denise.
Hi there. Can you see me? Am I on screen?
I believe you are. Yes, I'm going to jump off and let you do your thing.
Okay. Hi, everyone. Thank you for being here and making time to join this session of EHE 360 Connect. I am very pleased to introduce Dr. Scott Schuetze, who's a medical oncologist and clinical professor at the Rogel Cancer Center at the University of Michigan. Dr. Schuetze's clinical practice focuses on the treatment of sarcomas, of which EHE is an ultra-rare subtype. He is an active researcher. He's involved in clinical trials of novel drugs for the treatment of sarcomas. And in 2017, importantly for this presentation, Dr. Schuetze led the implementation of a phase 2 study of Trametinib, which is sold under the brand name Mekinist, in patients with locally advanced or metastatic EHE. And that was at 16 institutions across the United States. So this study was sponsored by the NCI, the National Cancer Institute, and it was monumental for the EHE patient community while the study was not deemed a positive study, and Dr. Schuetze will explain that further. A lot was learned from this study that today informs care decisions and clinical trial design for EHE. And before I hand over to Dr. Schuetze, I want to say thank you to the patients who participated in this study. I also want to sincerely thank Dr. Schuetze and Dr. Brian Rubin from the Cleveland Clinic. Both have made significant contributions to this study and to the analysis of the data. Additionally, I want to say thank you to the other investigators, all of whom you will know as EHE expert doctors, and their supporting research teams at those institutions. Without these people and the funding and the sponsorship of the NCI, the administrative support given by SARC, this study would not be possible. So as Maggie mentioned, please share your questions in the Q&A box. We'll go through questions after Dr. Schuetze goes through his presentation. And now I want to turn it over to Dr. Schuetze. Welcome and thank you for being here.
Good afternoon or good morning, I guess, depending on where you are. I'm Scott Schuetze, medical oncologist at the University of Michigan, and I'm very happy to be invited to come today and present to you on our work, which evaluated a drug, Trametinib, or Mekinist, in the treatment of patients with locally advanced or metastatic EHE. So let me go ahead and share my slides. Great. All right. So as Denise mentioned, this trial really was possible through significant collaboration amongst a number of different groups. The NCI Experimental Therapeutics Clinical Trials Network, or ETCTN, was instrumental in allowing us to conduct this trial. The NCI provided the drug Trametinib through an agreement they had with the pharmaceutical company that makes this medication. They also provided funding to the sites for the sites to enroll participants and to enter clinical data into the database, and they provided access to the clinical trials database, which was managed through a company called Medidata. SARC was also very helpful and instrumental in conducting this trial. SAR coordinated patient screening amongst the different sites. They also help coordinate the collection and shipment of biosamples of the required pathology and of the questionnaires that were completed. And they also helped with maintenance of the database for the questionnaires, for the answers on the questionnaires, and also as the results of some of the biosample and pathology testing. The EHE Rare Cancer Charity in the UK provided funding for optional tumor biopsies that some participants elected to sign up for. And then the EHE Foundation was instrumental in providing support for patients and referrals to the sites that had the study activated. They are also very helpful in broadcasting information about the availability of this trial and the progress of the trial through the EHE Facebook. Just to start with a little bit of an overview of EHE. EHE, as you know, is a malignant vascular tumor, a sarcoma that's derived from the endothelial cells. These are the cells that line blood vessels. And work that's been performed by Dr. Rubin in his lab and his colleagues have really established that the endothelial cells are the cells of origin for the development of EHE. And there's a critical event that occurs within these cells that results in a translocation of a gene called WWTR1 with another gene called CAMPTA1. And this fusion of these two genes results in a fusion of a protein that is pathogenic in the cells and leads to the development of EHE. And this translocation resulting in a fusion protein results in activation of multiple pathways within the cells, including the MAP kinase pathway, the RAS pathway, vascular endothelial growth factor receptor pathways, and the mammalian target rapamycin pathways. And it's believed that activation of these different pathways generates the malignant potential of the cells. And shown in these cartoons here, the middle cartoon shows that this is the WWTR1 gene, and this gets translocated and connected to this CAMPTA1 gene. There's two different types depending on which exons are present in the WWTR1 or gene or TAS gene that gets connected to the CAMPTA1 gene. There's a related vascular neoplasm to EHE that has a translocation involving the YAP1 gene with TFE3, and this also results in an EHE-like tumor. However, patients with this particular translocation seem to have a less aggressive form of the disease. Now, Dr. Rubin and his lab have done a lot of work evaluating the biology of EHE, and what work that they've done has shown that this fusion protein between TAS and CAMPTA1 results in expression and secretion of connective tissue growth factor, which then is secreted from the cell and can bind to integrins on the cell surface. And through the binding of this connective tissue growth factor with the integrin, it leads to signaling and activation of RAS and the MAP kinase pathway. And one of the components in the MAP kinase pathway is an enzyme called MEK, and the drug Trametinib, amongst other drugs in the same family, are able to block or inhibit the activity of this MEK kinase, which then prevents further signaling in the cell. And what Brian Rubin's lab has shown is that this medication, Trametinib, in blocking the MEK activity leads to some disruption in the malignant phenotype of the tumors. So we hypothesized it based on a lot of the work that was done by Brian Rubin and his laboratory associates and others, was that treatment of patients with a MEK inhibitor would result in objective tumor response or shrinkage of the tumors, would prolong progression-free survival. And we also thought that it would reduce pain intensity related to EHE. And the reason why we thought this is that we thought that using a MEK inhibitor to block the MAP kinase pathway might result in downregulation of connective tissue growth factor, and it was thought that the connective tissue growth factor being produced by the EHE contributed to inflammation and ultimately pain associated with the cancer. We also thought that the presence of biomarkers of inflammation would associate with EHE behavior, such that patients who had higher levels of inflammation that was measured by a couple of different proteins that can be tested in the blood. The C-reactive protein is one, and erythrocyte sedimentation rate is another. The patients with higher levels of these markers of inflammation would have more aggressive disease. We weren't quite sure what would happen with connective tissue growth factor levels, whether they would decrease in patients on treatment, or if for some reason the blocking of the MAP kinase pathway would lead to some compensatory upregulation of connective tissue growth factor expression. But we thought that the levels would likely change with response to therapy. And so we designed a phase 2 clinical trial. The clinical trial had the primary objective of estimating the response rate of the tumor to treatment. And this was using RECIST, which is a standard set of criteria to reproducibly measure and assess tumor response to treatment. Our goal was that there would be at least 4 patients, if not more, out of 27 evaluable patients who had the presence of this fusion protein documented on pathology, that at least 4 of them would have a partial or complete response to treatment for the study to meet the primary endpoint and be evaluated as a success. We had a number of secondary endpoints, which included estimating the 6-month progression-free survival rate, as well as the median progression-free survival rate, the 2-year and median overall survival rates, to evaluate the safety of trametinib in patients with EHE, and to evaluate the effect on patient-reported pain and quality of life using validated questionnaires called PROMIS questionnaires that were developed by the NCI. And then we had some additional exploratory endpoints in evaluating the change in the C-reactive protein, erythrocyte sedimentation rate, connective tissue growth factor during treatment. So for participants in this study, the eligibility required that they had metastatic or locally advanced EHE with the pathology confirmed by the local pathologists, that there was documentation of disease progression or the presence of severe pain from EHE that required an opiate for treatment, such as the use of Norco or Percocet, for example. We included these 2 criteria because we know that some patients with EHE can have extremely indolent disease that grows very little over many years and doesn't cause any symptoms. And we thought that those patients would be less likely to benefit from treatment than a patient who had EHE that was progressing, that was growing, or that was resulting in inflammation that was causing severe pain. Patients were also required to have a performance score of less than or equal to 2. Normal kidney, liver, and heart function, which was assessed by blood work, and for the heart function by an EKG and an echocardiogram. No prior retinal vein occlusion. This is a very rare condition, but the MEK inhibitors may be associated with an increased risk for patients developing retinal vein occlusion, as well as pneumonitis or inflammation in the lungs. So to be eligible and to not put patients at increased risk of these 2 potentially severe complications or treated with a MEK inhibitor like trametinib, participants were required to not have a prior history of retinal vein occlusion or interstitial lung disease or pneumonitis. And participants registered in this study were treated with trametinib 2 milligrams orally daily. They completed quality of life and pain questionnaires prior to starting drug therapy, after 4 weeks of drug therapy, and 6 months later for those patients who remained on treatment. Blood testing for complete blood count and comprehensive metabolic panels were performed prior to treatment and then monthly on treatment to monitor for potential adverse effects. The blood markers of inflammation were measured prior to treatment after 4 weeks on treatment, and then after 6 months on treatment. So this shows the patient distribution of the patients who were enrolled in the study. Enrollment occurred between June of 2017 and March of 2021, and patients were enrolled amongst 16 participating sites. So it was a broadly represented trial across the nation. It was a US-based trial. 44 patients were enrolled. 2, though, chose not to start trametinib therapy after they were enrolled. And 42 participants started treatment. Of the 42 who started treatment, 25 stopped treatment because of disease progression ultimately. 8 patients withdrew from the study for a variety of reasons. Some patients, it was due to travel to and from their home in the site that they were participating through that became just not feasible for them. There were a few patients who withdrew because of some skin and hair effects that they thought were unpleasant, but didn't really meet the criteria for adverse effects requiring a stop in the therapy. There were 2 participants who went on to liver transplantation. So the 8 who withdrew was for a variety of reasons. There's at least 1, if not 2 patients who stopped the study treatment because trametinib became commercially available, and rather than continuing with the study, they continued treatment with commercial drugs off of the study. 3 patients withdrew because of adverse effects that developed, and 6 patients unfortunately died on treatment. There aren't any patients who are remaining on study treatment on this clinical trial, but there are patients who are remaining on trametinib treatment. So these are the results of the testing of the tumor tissue for the presence of this TAS-CAMTA1 translocation. And this was performed by a laboratory technique called a fusion FISH probe. And the photograph here is an example of this fusion FISH probe, in which what's shown here in the blue is a EHE cell, and there's a fluorescent label that is specific for the TAS gene, for example, shown in the red here. And then there's another fluorescent label that's specific for the CAMTA1 gene, shown in the green. And so when those genes are sitting on their normal chromosomes in an untranslocated or unfused state, you can see them as separate green dots or red dots. But when the translocation occurs, it brings the proximity of the TAS gene next to the CAMTA1 gene. And so those 2 dyes come into close proximity. And as seen on here, the red and the green sort of fuse, and you can see a yellow fluorescence. And so that yellow fluorescence with those 2 markers in close proximity is basically demonstrating the fusion of the TAS to CAMTA1. And so if that yellow dot there is present, then that's considered a positive or detected fusion. And if you can't see the yellow dot and the the green and the red markers remain distant from one another in a cell, then that's considered not detected. The fusion only happens in 1 set of the chromosomes. So you have generally in each of the cell, you'll just see 1 fusion and then 1 unfused chromosome pair. So out of the patients that we received tissue samples on to test in the lab, and this was performed in the one of the molecular labs at the Cleveland Clinic, there were 27 cases in which we detected this TAS-CAMTA1 fusion. There were 7 cases in which it was not detected. At least in one of those cases, the patient had the YAP TFE3 fusion. In a couple other cases, it was felt that the tumor wasn't EHE, it was another vascular tumor. In 3 cases, there was insufficient tumor material in the samples that were submitted by the site to do the test. And then in 5 cases, the test failed for technical reasons, which can happen sometimes. Since we developed this test and performed this test in the clinical trial, laboratories have developed an immunostain, which is an antibody that stains for a protein campta-1. And so this immunostain is often done on tumor samples, demonstrating the expression of campta-1 in the nucleus. And that generally is a an indication that, or within the cell, that indication that the tumor is an EHE. And so this fusion fish laboratory technique is done less often now. These are tables showing characteristics of the patients who participated in this clinical study. The mean age was 52, but we had a wide range of patients, as young as 22 and as old as 81 participated. I think of importance, 27% of the patients were 65 years of age or older. There were more females than males that participated. Most of the patients who participated were white and were non-Hispanic, although we had a few patients of other race and ethnicities that participated. Most of the patients had a really good performance status, an ECOG of 0, which means that they have few, if any, symptoms from the EHE and are able to perform all of their normal activities and work. 18 patients had an ECOG of 1, meaning they had some symptoms from the EHE, were able to perform normal activities, but generally not work. And 3 patients had an ECOG of 2, meaning they had more significant symptoms from the EHE, which did impact some of their normal activities. Of the patients that participated, 18 had tumor that primarily arose and involved the lung or the pleura. In 14, it primarily involved the liver. In 7, it primarily involved bone. In 4, soft tissue. And in 1 patient, the primary site was unknown. And this is pretty typical for what we see with patients who have EHE. Now this graph here shows what we call a waterfall plot. And this is the response, the best response of the EHE tumor to treatment. Each column represents an individual participant. And an increase shown on the left shows that there was some increase in the size of the tumors, the target tumors that were being followed for response. The red line shows a 30% decline in the sum of the target lesions, and anything more, 30% or more of a decrease in the size classifies as a partial response of the tumor to treatment. And as you can see here, there are 4 participants that met this criteria for having a partial response in their EHE to treatment. But the majority of the patients had some minor reduction in the size of the EHE on treatment, although the magnitude of the response wasn't sufficient to reach this threshold of needing 30% or more reduction to be scored as a partial response. So the overall response rate was 9.4% for all of the patients that enrolled, and 11.4% for the patients who were evaluable for response. Some patients were not evaluable because they did not have follow-up scans done after starting treatment. Now, these 4 people who had a partial response, one of the responses occurred in somebody who had the TAS-CAMTA1 fusion detected in their tumor tissue by that fusion FISH test. 2 of the patients did not have the TAS-CAMTA1 detected. It wasn't present. And in 1 of the patients who had a partial response, there was insufficient tumor tissue to detect the TAS-CAMTA1 fusion. So the presence of the fusion in that 1 patient's unknown. This is what we call a swimmer's plot. This shows the time on treatment of the participants, and each row is an individual participant, and it just shows the days from the start of treatment that the patient remained on treatment with Trametinib. The patient at the top who did the best is a patient who was thought to have a bone hemangioma, not an EHE, on central review by Dr. Bryan. There was 1 patient here who had a partial response to treatment. The second participant who remained on treatment for the longest and remained on treatment for about 2 years. And these 2 curves here show what we call Kaplan-Meier survival curves, which provide an estimate of progression-free survival on the left and overall survival on the right. And this shows that there was the median progression-free survival was about 8.3 months, meaning that the median time that patients remained on treatment without having tumor progression was 8.3 months. Half the patients, the tumor progressed more rapidly, and half the patients less rapidly than that. And the orange curve shows the patients who we were not able to detect the presence of the TAS-CAMTA1 fusion for the variety of reasons as previously mentioned. And then the teal or bluish line shows those participants in which we were able to detect the presence of the TAS-CAMTA1. And as you can see, there was really no difference in the progression-free survival or the overall survival of the patients in which we were able to detect the presence of the translocation or not detect it. The median overall survival for the participants on this phase 2 trial was approximately 22 months. But as you can see here, there's some patients who, as far as the kind of duration of the data that we collected, were surviving long after progression occurred. Now, regarding the adverse effects that participants experienced, there were quite a few, although most of them are relatively mild. Adverse effects affected the skin. So patients reported rash, hair loss, and edema or swelling. The drug treatment also affected the GI system. So some patients reported anorexia or loss of appetite, some change in the sensation of taste. There was some nausea, vomiting, diarrhea, constipation, and some mouth sores. Number of patients reported fatigue or dizziness. Some reported cough or dyspnea. In a few patients, it was more serious and resulted in pneumonitis or inflammation in the lungs. And in one patient, a process called acute or adult respiratory distress syndrome. Patients reported some blurred vision, although importantly, there was no occasion of a retinal vein occlusion or any effect on the retina. And the most common hematologic adverse effect that was reported was anemia. There was relatively little thrombocytopenia or low platelet count or low white blood cell count. As I mentioned, patients started treatment with 2 milligrams daily. However, in half of the patients, the dose was ultimately reduced to 1.5 milligrams per day, primarily because of adverse effects. And then out of that half that reduced the dose to 1.5 milligrams per day, another half reduced the dose to 1 milligram per day because of adverse effects. Now, this shows some results of the patient-reported questionnaires, focusing mostly on pain. And what's shown here are the sort of a box and whisker plot of the responses. And for the pain intensity on the left, the blue mark shows what is sort of the expected value of a population of normal patients, patients who don't have a significant disease. And so as you can see, the baseline, the mean score for pain intensity is significantly higher than what would be expected for a normal population. But importantly, after 4 weeks of therapy, shown in this middle graph here, that there's a significant reduction in the pain intensity, and it's approaching what is sort of expected for the normal population. And then after 6 months of therapy, for the patients who are, importantly, this is for the patients who are remaining on therapy for 6 months, the median pain score is actually slightly less than what is reported for a normal population. And then for pain interference, we also saw improvement. And pain interference is basically a questionnaire that asks about how much the pain is interacting or interfering with normal activities, with work, with doing household chores, that sort of thing. So is the pain interfering with your usual activities of daily living? And this shows that, again, the blue mark is what would be expected for a normal population. And for patients with EHE in this trial, the pain interference was significantly higher at the start prior to starting treatment. And then in the middle is after 4 weeks, there's significant improvement or reduction in the pain interference, although not quite to the level of a normal population. And that improvement is maintained after 6 months. And then the third group here is pain behavior scores, showing the pain affecting a person's behaviors. It's significantly worse for patients with EHE in this trial at the start. And there was some improvement after 4 weeks of therapy, but again, not quite to the level of what would be expected for a normal population. The global physical score is the impact of the EHE on a patient's just general physical condition, showing that the EHE patients had a significantly lower kind of global physical score than what's expected for a normal population, showed at the blue arrow. On Trametinib, there was not any significant improvement in their physical score, even though there was some improvement in their pain scores. Now, looking at the different biomarkers that we evaluated, some studies have suggested that hemoglobin can serve as a biomarker. So patients who have normal or high hemoglobins may have a better prognosis than patients who have anemia or low hemoglobin. We also looked at, as I mentioned, the C-reactive protein, CRP, erythrocyte sedimentation rate, ESR. And then we also looked at connective tissue growth factor. And we looked at these levels in patients' blood prior to the start of treatment, after 4 weeks of Trametinib, and then after 6 months for the patients who were still on treatment at 6 months. We also looked at sex, female versus male sex, as prognostic biomarkers for progression-free survival and overall survival. And some of the lab results, the hemoglobin, CRP, and ESR, were determined by the standard clinical labs at the participating sites. For the connective tissue growth factor, blood samples or plasma samples were shipped to Brian Rubin's lab, and the assay was performed in Brian Rubin's lab using a commercial kit that's available. The median follow-up duration for the patients with respect to these biomarkers and time on treatment was 540 days, so almost 2 years. So these were the results of the effect of hemoglobin on patients' prognosis, on their progression-free survival, and their overall survival. We established 12 grams per deciliter as a normal hemoglobin level. And 23 of the participants had a baseline hemoglobin prior to the start of therapy of 12 grams per deciliter or higher. In 18 patients, it was less than 12 grams per deciliter. So we would consider that to having some degree of anemia. The median hemoglobin in the patients was 12.1 grams per deciliter, and the range or the participants was from as low as 1.9 to as high as 15.1. And what's shown here in these Kaplan-Meier survival curves, on the left, progression-free survival, on the right, overall survival, is that the participants that had a normal hemoglobin at the start, at entry into the study, had a much lower risk of progression of EHE, so their progression-free survival was more prolonged compared to the people who are anemic or had low hemoglobin, shown in the orange at the time of study entry. And this also equated or sort of resulted in an impact on the patient's survival. So those participants who had a normal hemoglobin had an improved overall survival duration compared to the participants who had anemia going into this trial. And this slide here shows the results of the C-reactive protein levels that were evaluated. What's shown on the left is that the value of the C-reactive protein at baseline compared to the value after 4 weeks. In many patients, the value was very low and it stayed low. In some patients, as seen on this line here and this line here, these two lines here, the value was high to start with and it decreased on treatment. In some participants, as shown here and here, and even here, the levels were lower, but they increased markedly after 4 weeks of treatment. although there were very few people that had a significant change like this on treatment. But the analysis that was done by the statistician using what's called a hazard ratio type of analysis showed that for participants who had a baseline CRP level or a change in the CRP level after 4 weeks, that was more than 1 gram per deciliter, more than 1 milligram per deciliter, that there was an increase in the risk of tumor progression. So for each 1 point increase there was, based on this, there's an increase in the risk of progression of 23% compared to patients that had a very low level of C-reactive protein. And this effect, this sort of higher marker of inflammation, also affected participants' overall survival. So people that had higher levels of CRP had a shorter survival duration than patients who had a very low CRP level. And we also looked at the erythrocyte sedimentation rate. This did show that patients with a starting higher level of the erythrocyte sedimentation rate at the start of treatment was associated with the shorter survival, but not with progression. And the change was not associated with EHE progression or survival. So this marker, erythrocyte sedimentation rate, which measures inflammation in a little bit of a different way than C-reactive protein, didn't seem to be as good a marker, as good a biomarker for progression-free survival and overall survival as the C-reactive protein. And this just shows the values here. The median value was 33, and this is measured in millimeters per hour. 33 with after 4 weeks of treatment, it was 44. So there was a little bit of an increase overall, but the change wasn't all that significant, and it didn't really correlate with progression or survival. And then we also looked at connective tissue growth factor levels. As we mentioned, we weren't quite sure what to expect from this at the start of treatment, whether or not this level would decline or would increase. And interestingly, we didn't really see much effect of the trametinib treatment on connective tissue growth factor levels in participants. So the median level was in the blood was 53 micrograms per deciliter prior to the start of treatment, and 50 after 4 weeks. So there really wasn't a significant change. There was a pretty broad range from 26 to 160, which really didn't change on therapy. So the measuring connective tissue growth factor levels didn't really seem to provide additional information. So just to summarize what we've learned from this phase 2 clinical trial of trametinib in patients with EHE, that collaboration amongst a number of very important institutions can lead to successful completion of a clinical trial of modest size in an ultra rare tumor. This was really accomplished through the incredible collaboration between the EHE Foundation, the Rare Cancer Charity, the NCI support, and SARC, which contributed to the successful completion. Trametinib may be beneficial in patients with severe pain and or progressing EHE, not so much through resulting in significant reduction or partial response in the tumor to treatment. As I mentioned, we only had one participant who had the presence of the fusion of the tumor documented that had a partial response. So the one didn't hit our threshold of 4 or more in order to say that this treatment results in significant tumor response, but we did have a prolonged progression-free survival for a number of patients, and we saw that important improvement or reduction in the severe pain that some patients experienced from EHE. We also have found that EHE patients without anemia have a better prognosis. So if patients have a normal hemoglobin, they have a 66% lower risk of EHE progression and a 67% lower risk of death from EHE, at least amongst the population of participants in this trial. We also found that EHE patients with a normal or a low C-reactive protein level have a better prognosis. And one can therefore suggest that EHE patients who have a low hemoglobin, anemia, and a high CRP, they might need more aggressive therapy. And on the converse, patients who have a normal hemoglobin, so no anemia, and a low or normal CRP, they may have very indolent disease and not really need treatment right away for the EHE. And then finally, the connective tissue growth factor levels that we measured didn't really seem to have any significant prognostic or predictive effect of how patients would do with trametinib therapy. All right, so I just want to acknowledge the EHE Foundation and the patients and family members for their support of this trial, and thanks to our collaborators, all of the institutions that the academic medical centers that helped enroll patients and treat patients, and to SARC for their terrific coordination of the biosamples and the managing the data. And special thanks to Aaron, who provided critical coordination at SARC. Aaron has recently left SARC for other career pursuits, and then to Rachel Heiss, who is at Columbia, who helped to perform the majority of the biostatistics. All right, and I'll end it there. I think we have about 15 minutes for questions.
Yes, thank you very much. That was great. Having read your paper and seeing some of the data, it's great to see this again. And I can't thank you enough for all the time that you and Dr. Rubin and everyone put into this study. Really helpful. And I, my hope is that really it's informative as we go forward and have more EHE clinical trials to give us care options for patients. So we have a couple of questions that have come in, and I'm going to jump to those, and I'm going to do a little bit of combination because we did give people the opportunity to submit questions when they registered for this. So there's a little bit of a combination theme here. There was a question submitted by a participant saying, how does this medication compare to sirolimus in effectiveness? And there's a combination question there regarding the switch, if you could switch from sirolimus to start trametinib. And then here in the Q&A, along the same lane, there's a question regarding combination therapy with sirolimus. So there's a theme there. Any thoughts on all of that?
Sure. So we didn't restrict patients for this trial based on the number of prior therapies or the type of prior therapies they'd had, as long as they hadn't had a MEK inhibitor to treat the EHE. So there were a number of patients that had sirolimus. There were a number that had pazopanib, for example, or one of the other VEGFR inhibitors. There were patients that had prior chemotherapy that participated on this trial. So the one can certainly think about switching therapy if one drug isn't working, if sirolimus isn't working, switching to trametinib or vice versa. We don't have direct comparisons between the trametinib and sirolimus to know if one is definitely better than the other in treating the EHE. What I can say is that there were quite a few patients in our trial that had effusions, mostly pleural effusions, but also some peritoneal effusions that were associated with the EHE that seemed to have some benefit from trametinib. And we know from some of the prior publications that sirolimus seems to be less active in people with EHE who have effusions. So there may be a little bit of difference between the drugs in some subsets of patients with EHE. The trametinib might be better if you do have effusions than sirolimus, for example. There isn't any data on combination therapy, as best I know, with sirolimus or other mTOR inhibitor and trametinib. There is a publication that was a phase 1 clinical trial combining pazopanib with trametinib. So there is a little bit of data on that combination. So that's something that could potentially be considered for further exploration in the treatment of EHE.
Great, thank you. I hope that we can explore combination therapies going forward, and even re-explore this drug. So there is a question also from the audience, are there any data on patients using this drug who are no longer in the trial? So this goes to, I think we were discussing this earlier, long-term follow-up of these people who were in the trial, and where are they now?
There were a couple of patients who continued the drug Trametinib once it became available commercially, and they could get it just through their physician, their oncologist, without being a participant in the trial. As far as I know, they're still doing well on treatment, but I don't know who's been on the longest or how long that longest person has been on.
Yeah. Yeah, so the protocol didn't specify to do that long-term follow-up, so we don't have a formal, we won't have formal data on that really to present back.
Right, and we also didn't collect data on what subsequent types of therapy patients had after they came off of the Trametinib drug.
Right. Yes, that's correct. Good point. I want to go back to an earlier question that was submitted. This was a two-part question. If you have any thoughts on the viability of CAR T in the treatment of EHE.
So CAR T cell therapy requires there to be a protein that's expressed on the surface of the cell that's unique for that cancer, or relatively unique for that cancer. And most of the proteins that are expressed on the surface of the EHE cells are also expressed on normal endothelial cells. So it'd be hard to separate out the T cell attacking the EHE from attacking your normal endothelial cells and blood vessels. There are some T cell therapies that are designed to go after the fusion protein component of cancers. That is currently investigational, whether or not that could potentially be developed for EHE treatment based on the TAS-CAMTA1 translocation, which creates sort of a unique protein antigen that could potentially be targeted. That might be an option. Unfortunately, those kinds of T cell therapies are very restricted to people who have certain tissue types, what we call HLA types. So they're good for some people, not so good for others.
Okay, good, thank you. I've got a question in, it's from a researcher. I'm going to read this out to you. It's a little bit long, so I want to make sure that I get it correctly. And he says, if I understand the enrollment criteria, most of the patients enrolled had evidence of progression. Does this mean the tumors were increasing in size up until the start of treatment? If so, it seems that even though only one patient showed a 30% reduction in tumor size, Trametinib does appear to halt tumor growth, as most patients did not show continued tumor growth. And I'll add to that, but yet we still don't have really a positive study. Can you expand on that, on the kind of question comment there?
Sure, yeah, so patients to be eligible to participate either had to have tumor that was growing, that was progressing, or they had to have severe pain requiring treatment with an opiate. So not all of the patients had tumor progressing. Some of them it was just causing bad pain. We did collect images, so we collected CT scans, MRI scans, and we have those in a central repository. And one of our future efforts is to look at those scans and look at the trajectory of the tumor growth, sort of the pace of the tumor growth before starting treatment, and then compare that to the pace of the tumor growth after treatment. And we do think that even though there wasn't significant reduction in the size, we think that the Trametinib treatment did actually slow or halt tumor growth in some patients. We just don't know the number yet because we have to take a look at that, all those scans and try to do that work. That's just going to require, I guess, a little more funding. But we do have this in a central repository, and we do have a radiologist who has shown interest in doing some of those analyses for us. So we may have some information in the future about that. And I think that'd be important in designing the next trial, would be to look at that, to look at actually the progression-free survival and more critically document the rate of growth of tumors before participant enrollment and starting of the new therapy, and then compare that to the progression or the growth after starting treatment. Because that likely is going to identify a stronger signal than looking at objective response.
Mm-hmm. And there's been, conversation regarding RESIST as a limitation for diseases like EHE and clinical trials. Do you have any thoughts on that and how that could be a limitation in this study, or perhaps a better approach, an improvement on that approach?
RESIST can be a challenge. It's very, if you the RESIST response to getting an objective response. If you see an objective response, then you can be pretty confident that the drug's actually having an anti-cancer activity. If it's just having an effect on progression-free survival, that's a little harder to prove in a single arm trial. It really requires a randomized or a multi-arm trial to compare one group to another group to show that the progression-free survival is significantly better in one group versus the other group. So moving forward for EHE studies, maybe doing a 2-arm comparative trial or randomized comparative trial, looking at 2 different interventions, and with a goal of improving progression-free survival might be more successful than trying to do a single-arm trial where we kind of have to rely on objective tumor response for a true assessment of drug activity.
Okay. Yeah. Thank you. As you're just to get into another question that came into our registration questions, and I'm expanding on this just a little bit. But as you are in clinical practice, looking at EHE patients, what are some of the considerations that you give to whether or not to start treatment, systemic therapy? Local therapy, a little bit different, because that's something that you feel like you can have maybe an effect with local treatment. But with systemic therapy, what are some of those considerations that you and patients think of in thinking about starting a drug like this?
Sure. Yeah. For local patients with local therapy, we try to do surgery, if possible, if it's in a soft tissue location, radiation. Sometimes if it can't be easily removed or it's in the bone. In the liver, we've done a combination. In some circumstances, surgery, and others we've done more of a directed therapy like radiation or an interventional procedure like with radiofrequency ablation or cryotherapy, for example. For patients who have metastatic disease, the 2 things that are the most important to assess are, is it causing any symptoms, and then is it growing? And so for the patients in which the EHE is not causing any symptoms and it's not growing, then I just recommend monitoring for most of those patients. And sometimes you don't know if it's growing or not because they've only had sort of scans at one time point. But if they don't have any symptoms, say, look, we'll just kind of hold off right now. We'll get some scans in a couple of months. We'll take a look and see. If you don't see any change in a couple of months, okay, we'll do another scan in 4 or 6 months and see if it's changing. And then you kind of start spreading out the scans a little bit. I think now, based on what I know from this data, looking at the C-reactive protein level and looking at their hemoglobin, whether or not anemia is present or not, are other 2 areas that we could look at it. So if a patient has a normal or low CRP and a normal hemoglobin, then I'd be more comfortable observing them if they don't have any symptoms from the EHE. If the EHE is causing symptoms, if it's causing pain, if it's causing, if there's inflammatory symptoms that are present, then I think I'm more compelled to offer treatment for those patients. And the type of treatment to use really depends on whether or not there are other factors, other medical conditions that are present. I have a number of patients who had significant improvement in pain from Trametinib, so I'm usually kind of thinking about Trametinib if they have a lot of pain and we're trying to alleviate that pain. I think sirolimus is another good option for some patients that don't have effusions, like pleural involvement in effusions. If they have pleural involvement in effusions, then I'm thinking more about maybe using pazopanib or Trametinib. In some patients who have really aggressive disease, I think treatment with chemotherapy like gemcitabine and docetaxel or gemcitabine sometimes can offer some benefit. We do have less data on those types of treatments, but gemcitabine and docetaxel and gemcitabine are good treatments for other kinds of vascular cancers like angiosarcoma. So I think there is some benefit from those treatments in certain circumstances.
Good. That's a good, I'm glad that we're learning from this study, and I look forward to us doing more, getting more data on these biomarkers too. Let me look real quickly to see if we have, I'm mindful that we have like couple more minutes. There's an expansion on the question. You mentioned this regarding effusions. I don't believe there's a lot of data, but the question is, can you expand on data regarding effusions and this treatment? And I'll leave that to you. I don't think there's a lot more.
Yeah, we didn't see a big difference in outcomes if we were able to document the fusion in the EHE sample or not. So I think that patients without the fusion could benefit from trametinib treatment, and patients with the fusion could also benefit from trametinib treatment.
Okay, good. I don't see any other questions right this second. And I don't think that, yeah, I'm just checking all of my sources here for questions that have come in, and I don't see anything else. So I think that without anything else, I'll say thank you very much. We do look forward, if you have the opportunity and funding. We realize that now that is going to be a larger leap, possibly to get funding to review those imaging files that you have from these patients. And I think that, for me, the key takeaway is we really need more data from patients, because studies like this are limited in the data that you've collected by design. You've collected what you've gotten. And so if we as a patient community can help bring forward more data, and we thank patients who participate in these studies, these and other studies, that will be helpful so that you'll have other data to look at in comparison in future studies.
Yeah, that would be great. And
Yeah.
yeah, we're definitely interested in more research in EHE.
Yeah, no, we are, we look forward, the landscape is changing, which is a good thing. TEAD inhibitors, more TEAD inhibitors coming into clinical trials is excellent. And the more we can learn from those studies and these other studies where we can repurpose drugs would be great. So let me see. Don't think there's anything else.
They said they just sent in a final question.
I saw that, and I'm looking to see if I can find the final question here. I've got too many pop-ups going. Yeah, so just ask, would it be possible to briefly share your thoughts on future for possible curative treatment for EHE?
Oh, well, geez, I don't know. I think, Brian Rubin's been doing a lot of work with his mouse model on EHE, and I think that's probably a really good model to study possible options that could be curative. And if we can cure things in the mouse, we don't necessarily are able to cure it in the human, but I think that's at least a good start for where to go for treatments. And I know he's got a lot of ideas right now about possible new therapies that we could explore in clinical trials for EHE. So I think that curing it is going to probably require combinations of different interventions. We're probably not going to be able to cure it with one drug alone, but just trying to find the right mix of drugs, or drugs with immunotherapy, drugs with other kinds of therapies. There's a lot of work being done with what's called antibody drug conjugates, where an antibody brings a drug right to the EHE cell and can more effectively kill the cells. That might be a way to go in the future. But I guess I think we'll get there. It's just going to take a lot more research and innovation.
Yeah. No, this is great. Thank you very much.
Brian P. Rubin at the Cleveland Clinic has a mouse model.
Yes.
And it's doing a lot of work on EHE.
I'll point out, if you go to the library at fightehe.org, you can read papers that are, and I don't know if Maggie has the opportunity, can put that link in the chat or in the Q&A, but there are papers on all of this, and Dr. Schuetze's paper that was published last year, they're all linked there, so you can read all about this And this session will be, it was recorded and it will be posted later on, probably this week, so that you can rewatch it and send us any questions. Thank you. Thank you, Dr. Schuetze, for making time
Thanks so
today.
much.
Thanks
Yep.
everybody for being
Have a
here.
nice afternoon.
Really appreciate it. Thank you. Be well.